pancreatitis. The pathophysiology: there is an insult to the pancreas, there's a damage to the endoplasmic reticulum, there's an increase in intracellular calcium, and inactive trypsinogen is converted to active trypsin, which activates all the other pro-enzymes, and there's autodigestion of the pancreas. The pancreatic enzymes include proteases, which are 77%, trypsin, chymotrypsin, carboxypeptidases, and elastase. Lipases are pancreatic lipase, there's colipase 1 and 2, phospholipase A2, CEL. Glycosidases, alpha amylase, nucleases, ribonuclease, deoxyribonuclease. Amylase is non-specific and lipase is specific. The amylase has a short half-life, and therefore it's useful to detect recurrent acute pancreatitis, to know if there's any new episode. The amount by which it rises is not significant, but it needs to be more than 3 times the upper limit of normal to cause it significant. Lipase similarly needs to be more than 3 times the upper limit of normal. Protection from autodigestion in the normal state is because the enzymes are in the inactive form. The activating enzyme for trypsinogen conversion to trypsin is distant, that is enterokinase in the duodenal mucosa. Then the zymogens are compartmentalized and intracellular calcium is low. Ductal bicarbonate keeps trypsin inactive. There's also a co-synthesis of trypsin inhibitor, example SPINK1. Post-ERCP, 50% have an elevated amylase, but that is not pancreatitis, because for pancreatitis there have to be at least 2 out of 3 criteria to be present. One is typical pancreatic pain, which is epigastric pain radiating to the back, associated with vomits and with post-meal worsening. Second, the amylase or the lipase have to be elevated more than 3 times the upper limit of normal. And third, there should be an ultrasound finding or CT finding or MRI finding suggestive of a pancreatitis. Local complications of pancreatitis include an acute collection, pancreatic abscess, pancreatic hemorrhage, pancreatic phlegmon, and a pseudocyst or a walled-off necrosis. According to revised Atlanta 2012 criteria, there are 2 phases, early and late. Early is due to SIRS or MODS and it's less than 1 week. Late is due to, and late complications are because of infections. There's increased morbidity and mortality. And severity scoring is mild, moderately severe, and severe. And mild is when there's an absence of organ failure or local complications. Moderately severe is the presence of organ failure or local complications, but it resolves within 48 hours. And severe is if that lasts for more than 48 hours. The collections would be acute pancreatic fluid collections, APFC, which is sterile, which is it's from interstitial pancreatitis, and it does not contain necrotic material. ANC is acute necrotic collection. Pseudocyst forms from an APFC, and a WON or WOPN is a wall of necrosis that forms 4 weeks after the ANC is formed. When do we do a CECT abdomen? The diagnosis, if it's unclear, the patient presents acutely and we're suspecting it could be a pancreatitis, but we have to rule out a perforation, then we do it, or a bowel ischemia. Second, to evaluate complications more than 48 hours. Example, a pseudoaneurysm producing a hematemesis because of rupture, splenic vein thrombosis causing a variceal bleed. Thirdly, if the patient is not improving beyond 72 hours or develops high-grade fever. The modified Marshall scoring for organ failure, its score is 1, 2, 3, and 0, 1, 2, 3, and 4. And the criteria taken into account are respiration, which is your PF ratio, 0 if it's more than 400, 4 if it's less than 100. Renal, which is creatinine, which is less than 1.4 is 0, more than 5 would be 4. Cardiovascular, which is systolic BP of more than 90 would be 0, less than 90 with a pH of less than 7.2 would be 4. Score of 2 is organ failure, And the definition would be a PF ratio of less than 300, creatinine of more than 2, systolic BP of less than 90, not responsive to fluids. And infected necrosis has a 15 to 20% mortality. Clinical scoring systems used are SIRS, which is Systemic Inflammatory Response Syndrome, in which you use a temperature, heart rate, respiratory rate, and WBC count. BISAP scoring, which is BUN more than 25, impaired mental status, GCS less than 15, SIRS more than 2, age more than 60, and pleural effusion. Each of these are given 1 point, and a BISAP score of more than 2 has a more than 20% mortality. Then there is a Ranson scoring, which is not used anymore. More than 3 out of 22 is associated with a higher morbidity and mortality. And Ranson scoring is done twice, at admission and at 48 hours. At admission, the age, WBC, glucose, LDH, and AST are estimated. At 48 hours, the PCV, BUN, calcium, phosphate, base deficit, and fluid deficit are calculated. And then there is the Apache scoring system. The most important bedside severity score would be a persistent SIRS. We can check a BUN of more than, if it's rising instead of dropping, or if it's more than 25, it's bad, and hematocrit of more than 44 or rising hematocrit is also bad. And then the BISAP scoring system. The etiology of acute pancreatitis, gallstones is the major one, that's 40 to 70%. It's said that even idiopathic pancreatitis, 80% of them are actually because of tiny gallstones. Alcohol causes 25 to 30%, idiopathic 15 to 25%, ERCP 5%, metabolic causes like calcium and triglyceride, drugs, trauma, infections, malignancy, especially in an elderly person that presents for the first time with an acute pancreatitis, the suspect carcinoma of pancreas, and also they present with new onset diabetes. Genetics, SPINK1 mutations, CFTR mutations. For etiology, the investigation would be an MRCP rather than a CT scan, because an MRCP would tell us if there's an annular pancreas, pancreas divisum, any small malignancy. We could either do an MRCP or an EUS. But CT scan is actually for complications of an acute pancreatitis, and it also gives you an idea of whether there is a background chronic pancreatitis, because you'll see some calcification. Treatment, first and foremost, is IV fluids. That's RL is the preferred choice of fluid, and it's goal-directed therapy. If the patient's hypovolemic, we give 10 to 20 ml per kg bolus. And goal-directed therapy is to maintain a MAP of more than 65, heart rate less than 120, urine output of more than 0.5 ml per kg per hour. Analgesics we use are paracetamol, tramadol, diclofenac, and then if that's not working, we give pentazocin. Diclofenac can be used if the patient does not have renal failure. There was a study done comparing diclofenac with opioids, and that was in AIMS, but that did not show any statistically significant difference between the pain control of both the groups. Diclofenac can be associated with hemorrhage, and it can cause kidney failure. The second step up would be fentanyl infusion or fentanyl patch and Tidal. The problems with giving prophylactic antibiotics in early, less than 1 week, would be resistance, microbial resistance, increased fungal infections, gram-positive infections. Feeding. Orally, we start the patient on oral feeds within 24 to 48 hours and definitely before 72 hours. If the patient's having pain on eating, then we put an NG tube. We can put an NJ tube if there's duodenal wall edema causing a gastric outlet obstruction. We give them 25 to 30 calories per kg and 1.2 to 1.5 grams per kg of protein. We give them a low-fat diet because fat stimulates the pancreas to secrete more enzymes. When is TPN indicated? TPN is only indicated if there is a paralytic ileus or there is a portal vein SMV thrombus causing, again, bowel ischemia. We give them TPN. Or if the patient is not taking feeds for more than a week, or if there's a large bleed or compartment syndrome. When do we do an ERCP? Within 24 hours, it has to be done if there's cholangitis. And cholecystectomy in a biliary pancreatitis is done in the same admission if the patient has mild pancreatitis. You can do it within 7 days. But if the patient has had moderately severe and severe pancreatitis, you do an interval cholecystectomy within 6 to 8 weeks. Local complications more than 4 weeks. Before this, I have to mention that there is a Waterfall trial that is very significant, and that showed that goal-directed therapy, rather than high volume of fluids directed initially, is supposed to be associated with a lesser mortality than giving large volumes of fluid. So they recommend 10 ml per kg of RL followed by 1 to 3 ml per kg per hour of IV fluids, that's RL. Local complications more than 4 weeks are infected necrosis, gastric outlet obstruction, extrahepatic biliary obstruction, symptomatic collections like pain and early satiety. Pure pseudocyst with no necrosis happens in chronic pancreatitis with duct leak and trauma. The problems with the PCD is that it can form an external pancreatic fistula, and the reason would be a disconnected duct. So the treatment should be a bridging stent or an EUS guided drainage into the stomach. To decide between a PCD and an EUS guided drainage of the pancreatic collection depends on, one, whether there is a good wall or no. If there's a thick wall, you can easily do an EUS. And it also depends on where it is located. If it's located toward the liver, PCD is preferred. If it's centrally located toward the stomach with the wall between the stomach and the cyst less than 1 centimeter, we can do it EUS guided. One meta-analysis showed if the ALT is more than 3 times the upper limit of normal, it's the strongest predictor of biliary pancreatitis with a positive predictive value of 95% if it's done within 1 to 2 days. Acute biliary pancreatitis has 30% mortality, and without cholecystectomy, recurrent pancreatitis is 30% in 6 months. Indications for urgent ERCP. 1. Acute cholangitis. We have to do it less than 24 hours. Persistent biliary obstruction, in which there's persistent pain and jaundice and plus or minus biliary dilatation. We can do an ERCP within 48 hours of the diagnosis. When is a biliary sphincterotomy the primary treatment? If the patient is a poor surgical candidate, and also a temporary treatment during pregnancy. Elective ERCP is done if there's a CBD stone on MRCP, abnormal intra-op cholangiogram, jaundice, and imaging suggestive of a CBD stone. Otherwise, we preferably do an EUS first, see whether there is a stone, and then proceed with an ERCP. And endotherapy in CBD stones, 50% have already been passed out by the time we do this. So there is biliary sphincterotomy, which augments pancreatic drainage, and if there's sphincter of OD dysfunction present, it helps. CBD clearance can be done using a basket, and stent can be put in a CBD if there is a cholangitis, and if you can't do a sphincterotomy, there is a coagulopathy, the patient's on blood thinners, there's a portal cavernoma or cholangiopathy, and if there's a large stone, so you can't remove it in one sitting, or you do just a partial clearance, then you need to put in a stent. Then CBD stent will be removed after the cholecystectomy. Pancreatic fluid collections. There's interstitial pancreatitis. In this, only 30% develop a pseudocyst, of which only 10% need drainage. And they're usually benign, diagnosis by CT scan, which there's less than 30% necrosis. Necrotizing pancreatitis, 50% develop warpen, And of these, 50% need drainage. And this has debris and solid components and usually gets infected. Necrosis seen on a CT scan is non-enhancing region inside the pancreas. Indications to drain a pancreatic fluid collection. 1. Infection. 20% of ANCs are infected, or if there's and cause ongoing organ failure and an increased procal. 2. If there's a mass effect causing gastric outlet obstruction. 3. If there's refractory pain, there's a weight loss. And 4. Ongoing organ failure. 40% have infected PFC. And compartment syndrome, bowel ischemia, bleeding because of a pseudocyst and its ruptured pseudoaneurysm. We diagnose an infected necrotizing pancreatitis if the culture is compositive from the drain or if there are air foci present in the CT scan. Suspected infected necrotizing pancreatitis if there's persistent sepsis or clinical deterioration, and the antibiotic of choice would be a third or fourth generation cephalosporin or carbapenems or fluoroquinolones. The principles of treatment of a pancreatic fluid collection according to PANTER trial. In APFC and ANC, you delay. You wait, you give nutritional support to the patient. If it forms a pseudocyst after 4 weeks, you drain. If it's a warpen, after 4 weeks, you drain. And if that's not better, you debride. Treatment options for pseudocysts would be a surgical cystogastrostomy or cystoenterostomy. This used to be the gold standard, now it's less preferred. PCD, unfortunately, it forms a fistula, so it's not preferred. Endoscopic drainage is the first line of choice. There's the conventional drainage, which is transpapillary if it's less than 6 centimeter collection, or transmural if it's more than 6 centimeters. You can do a cystogastrostomy or a cystoduodenostomy. 2013 randomized controlled trial showed EUS and surgical drainage both had equal success rate of 95%, but the quality of life, hospital stay was better in EUS. There's a 15 to 20% complication of transmural drainage. There can be bleeding, perforation, and the advantage of doing an EUS is you can differentiate between solid, debris, and liquid. You can even identify any blood vessels close by. %30 of patients have a disconnected duct. So if you do a PCD, the fluid will keep draining and the fistula will form. The advantage of surgery is that the recurrence rate is low, as pancreatic leak is also treated surgically. This would be the treatment of choice if it's a distal leak. Choice of stent, double pigtail plastic stents, it's at least 2 of them. The disadvantage is the procedure time is more, there's a risk of occlusion, and there's need for repeated procedures. FC stems, the advantage is it's a larger lumen, there's a less risk of occlusion, short procedure time, and decreased repeat procedure, but the disadvantage is the cost and the chance of migration. LAMS is lumen opposing metal stent. The complications would be 5 to 10% bleeding, perforation, stent migration. You remove the LAMS at 3 to 4 weeks. If the pancreatic duct leaks, the plastic stent has to be put lifelong, or you can bridge it with a PD stent. But it's not always possible, so you leave 2 plastic stents in the stomach. Drainage of a warpen. EUS guided drainage, if there's no improvement, then you have to do a necrosectomy. It may require 4 to 6 sessions to complete. Guidelines state you delay the drainage till 4 weeks to allow liquefaction and formation of wall, according to the EGA guidelines, because there is an increased mortality if you drain it early. The stepwise approach, according to IAP Pancreatology 2013, conservative treatment, PCD or EUS guided drainage, and then proceed to surgical or endoscopic debridement. VAD, which is a video-assisted retroperitoneal debridement. PANTA trial was an NEJM. It was a trial between open necrosectomy versus surgical step-up. And surgical step-up would mean a PCD followed by a VAD. In this, the drainage was enough in 35%. The major complication was 70% in open necrosectomy versus 40% in the surgical step-up. 1/3, you could avoid a necrosectomy. The tension trial showed it was between endoscopic step-up approach versus surgical step-up approach. So endoscopic step-up approach was EUS guided cystogastrostomy. You enter the cavity, do an endoscopic necrosectomy, which is a DEN, direct endoscopic necrosectomy. And for the surgical step-up, you did a PCD followed by a VAD. The major complication rate and the drainage rate was the same, but there was increased external pancreatic fistula in the surgical group. The best location for placing a stent endoscopically for necrosectomy is the lesser curvature proximal body. According to the Orlando protocol for WAPN, if there's a unilocular collection, you do single LAMS, which is single gate and has a 90% success rate. If there's more than one collection, multi-gated LAMS, you put a distal stent first and then a proximal stent. If there's disconnected duct, if the collection is 6 to 10 centimeters, you put a single LAMS, then you exchange with a plastic stent after clearance to prevent recurrence. If the collection is more than 10 centimeters, you have to put a modified multigate LAMS. And if there are extensive collections, you have to put a PCD plus a LAMS. You assess the PD by MRCP or ERCP after the pancreatic fluid resolution. If there's an intact duct, you remove the stent. If there's a pancreatic duct leak or a stricture, you do a transpapillary bridging stent. If there's a disconnected pancreatic duct syndrome, there's a permanent indwelling plastic endoprosthesis needed. Pancreatic duct leaks. This could be a pancreatic disruption, which there's a partial leak with an intact distal pancreatic duct, or a total disruption called DPDS. There's a total disruption here, and the pancreas is viable beyond. This is seen in surgery, trauma, acute pancreatitis, and some have ascites and a pleural effusion. It's suspected if there is persistent or recurrent external pancreatic fistula, pancreatic ascites, pleural effusion, internal pancreatic fistula. For DPDS to occur, the criteria should be minimum 2 centimeters of pancreatic necrosis. Upstream pancreas should be viable. There should be extravasation of contrast on ERCP and non-visualization of the distal pancreatic duct. EUS features of DPDS would be pancreatic collection, and PD enters the collection 90 degrees, and then you don't see any PD after that. ERCP is a gold standard with 100% sensitivity. The treatment would be conservative. Only in the first and second week, you just concentrate on giving them nutrition via the NJ. You can give them octreotide 50 to 100 micrograms thrice a day. Surgery would include resection and an internal drainage, and endotherapy would be a plastic stent indefinitely.